Dear friends, I'll be talking about learning methods for neuroendoscopy. Neuroendoscopy can be learned by human models, animal models, synthetic models, virtual simulators, and hybrid simulators. In human, training can be done when you assist or do live surgery, and also it can be learned on cadaver with or without augmentation of vessels and CSF perfusion, or even the tumor phantom can also be generated. Animal models also can be used for endoscopic training, and the commonly used models could be pig, sheep, lamb, because they have a similar anatomy to the human being in some of the structures. Animal tissue can be used for augmentations. This also can be done in live animals and also in dead animal with or without augmentation. Another model for training could be synthetic models. This could be simple model which can be used for basic training. The synthetic model could be 3D printing models, which could be exactly same as that of the human being and with the pathology inside. These model also can be augmented. The virtual reality simulator also can be used. One can also use hybrid simulators in which both physical and virtual realities model can be used for training. So the question is, why simulations? There are advantages of simulations. It reduces harm caused to the patient by the beginner. It increases efficiency by reducing the time needed for surgery in clinical practice. It increases the opportunity to repeatedly practice rare procedures. It can be performed in non-threatening environment in a tailored way. This can be done in a controlled environment. Most of the residency training program typically focus on micro neurosurgical training. There is a lack of learning facility for neuroendoscopy in most of the centers. Neurosurgery skill lab for microscopic and endoscopic technique with basic and advanced learning facilities should be there in all teaching hospitals. Postgraduate training centers should have a neuroendoscopic educational curriculum. Learning of neuroendoscopy differs greatly from microneurosurgery. Switching from microneurosurgery to neuroendoscopy can be challenging. As shown here, there are usually two types of skill. One is microscopic skill and another is endoscopic skill. To learn neuroendoscopy, you have to acquire both microscopic skill and endoscopic skill, which could be completely different, which I'll discuss in the next slide. Learning endoscopy is about taking advantage of the technique and overcoming the limitations of endoscopy by continuous training, as shown here. This is a Scott parabola. There are three stages of learning in this. One is the idea of learning the technique. B is the stage of increased enthusiasm because of the advantage of the technique, and C is the decreased enthusiasm because of the limitations of the technique. Most of the colleagues leave this technique at this stage because of the limitations and because of the complications which occur in the endoscopic surgery. So one should overcome the limitations of these endoscopic surgery. I have added a curve D. That means you have to overcome the limitations of endoscopic surgery. So in short, the learning of endoscopy is equivalent to taking advantage of endoscopic technique plus overcoming the limitations of endoscopic technique. The microscopic techniques are different from endoscopic technique. In microscopy, you need bayonet shape instruments. The surgical field should be at the center. There is no blind area. There is no change in the orientation. The drilling is easy. The instrument manipulation is also easy. Control of bleeding is easy. Images are 3D. As against this, in endoscopy, the instrument should be straight. The center of the field should be in the corner. The endoscope remains at the corner, so there is no obstruction in the manipulation of the instrument by the endoscope. There is a blind area in endoscopic surgery which you need to overcome. There can be change in the orientation if the camera rotates during surgery. That should be also addressed. There is a difficulty in drilling. The endoscope can get soiled. The instrument manipulation also can be difficult because the endoscope itself may obstruct manipulation of the instrument. There may be difficulty in control of bleeding. The image could be 2D images. There are various training methods, and there are advantages and limitations of each these training methods. We'll be discussing one by one. Reading surgical books, watching videos and lecture is one of the method of training. There is a large volume of resources giving insight about the method and technique. It is user friendly. It can be learned even when surgeon is away from the hospital. The limitations are it does not simulate operative experience and there is no hands-on practice. The other method is live human surgery. Human surgery can be performed by self or you can assist the expert. One can also watch unedited videos. It is best method in similar anatomy and the environment. It is considered as gold standard and it gives hands-on experience. The limitations are that there are limited working hours. There is limited exposure in the routine working hours under expert supervision. There is a risk of more complication when new technique is performed by the beginner. There is variability in the individual anatomy. Third training model could be cadaver training. It is classified in a wet model category. This can be used with or without augmentation of the vessel or the CSF, or you can also create a tumor. It is also in the less threatening environment, and the other advantage is that you have similar anatomy. The limitations are there is no bleeding or CSF leak in the ordinary model. Availability is also a concern and it may be costly. The other training model could be live or dead animal. This also comes under the wet model classification. These models also can be comparable to human anatomy in some animal. Sheep and lamb model can be used for nasal and skull base anatomy because of the similar anatomy. Pig model can be used for spine training. These model also can be augmented. The limitations are there are ethical issues, there are anatomical differentiations, there is no bleeding or CSF leak in ordinary animal model, and there may be a risk of zoonotic diseases. The other model could be synthetic, which could be either simple or 3D, exactly the same model as of the patient. The basic technique can be learned on simple model, whereas in the 3D technique, exact patient specific model can be made. These models also can be augmented. The limitations could be that these could be costly, especially advanced 3D models. There is no bleeding or CSF leak in ordinary models. The other training model could be virtual reality simulators. These are computer-based virtual reality simulators. These are computer-generated virtual operative field with haptic and tactile feedbacks. These are good for basic skill. These are reusable and modifiable models. There is a better representation of surgical procedure and anatomy. These also have inherent metrics for assessment. These are not considered equivalent to live surgery, cadaver, or animal models. There is initially a high cost. Haptic feedback are not as good as cadaver, and these are not able to give real tissue characteristic feedbacks. There may be web-based learning. This is good for basic skill. It is inexpensive. One can evaluate knowledge and decision making. Limitations are these are not considered equivalent to live surgery, cadaver, or animal models. There is no haptic or tactic feedback. There is a need to access computer and internet. The other training method can be hybrid, which is a combination of physical and virtual component. It provides real world training, integrating patient specific characteristic and virtual system. The limitations are that it is expensive and limited in use due to high demand of time and efforts needed to prepare and run these hybrid models. The fresh cadaver can be augmented, vascular augmentation can be done, cadaver can be cannulated in femoral artery or the carotid artery or artificial perfusion with pulsatile flow system, and using this microvascular training can be learned. Placenta can also be used. These can be connected to pulsatile flow system for training in different type of anastomosis and vascular surgery. Intradural augmentation can also be done. Cannulation of the cervical spine for intrathecal reconstitution of CSF can be performed. Tumor phantoms can also be used. One can use agar gel base, unsalted chicken stocks, food coloring for visual mimicry, iohexol for radiographic mimicry. Various procedures which can be learned using these augmented cadavers are management of the carotid artery injury, endoscopic endonasal CSF leak repair, carotid endarterectomy, extracranial to intracranial bypass, insertion of ventriculostomy catheter, spinal laminectomy with dural repair, intraventricular neuroendoscopy with septum pellucidum perforation, and third ventriculostomy. Some of the animal models also can be used because of the similarity to the human anatomy. One such model is a porcine model in which pig can be used because of the similarity in lumbar and cervical spine anatomy, but there is a religious issue with this. The other model could be ovine model in which sheep or lamb can be used, and these are good for skull base and sinus surgery. There is no religious issue or there is no ethical issues with the ovine models. These are reliable for head and neck surgery because of the similar consistency of the tissue and neurovascular structures. There are limitations of animal models. There is some difference in the anatomical features. There may be religious issues. there are risk of zoonotic diseases, and there is absence of bleeding in the ordinary model. Simple, indigenous, inexpensive model also can be made. This is our model. This is made of earthen pot, and the hole is made. The simple camera and LED light source can be placed underneath this hole. Precision can be practiced by dropping the rubber band on the pin without touching it. Likewise, the boiled egg can be used for simulation of the cellar floor, and drilling can be done without injuring the inner egg. Same way, the ice cream stick can be used for simulation of lamina. Removal of ice cream stick should be done on predetermined markings. Practice of cutting also can be done on predetermined on the square. Same way, inflated Foley's catheter can be placed inside the foam, which can simulate as a dura. The foam should be removed without injuring the underlying Foley's catheter bulb. The model for vessel bleeding also can be made. Similarly, microsurgical skill training also can be done using simple, inexpensive surgical skill lab. We have used inexpensive Indian microscope. Precision dissection and cutting can be learned using deep-seated simulations in which the plastic container can be used and the tissue can be placed at the bottom of this plastic tube, and by this method one can learn how to practice microscopic skill in a deep area, and the microscopic practice also can be done in the superficial operating area. Sphenoid sinus and the salata sca can be cut or drilled in a commercially available skull model. Chicken wing is fitted and fixed in the space created in the skull, and different endoscopic procedure can be learned. Similarly, sphenoid sinus and salata sca are cut in a skull model. Boiled egg is fitted in and the drilling can be learned. Bell paper is filled with the saline and is kept inside the skull model. The skull model is closed. The burr hole is made at a desired point, and the LOTA scope or any other scope is used for biopsy, hand-eye coordination. Septostomy can be done using this bell paper as a simulator, and even ETV etc. can be learned. As shown here, you can also pick up the seeds to learn hand-eye coordination, and the perforations can be made which can simulate ETV. The other simple model could be plastic material box of 20 into 22 into 28 centimeter. The animal tissue can be placed at a 8 to 15 centimeter depth, and different size ports are made for instruments manipulation at the lid of the box. Additional port can be made for endoscope. Endoscope can be placed in one of the port, and it is held by one surgeon or with the help of endoscopic holder, and the procedures can be performed on animal tissue. Blunt dissection can be performed on major retroperitoneal vessels or nerve. A combination of blunt and sharp micro dissection is used to precisely separate the aorta from the vein. Amniotic membrane in soda cup is placed, which can be placed in a big cup containing animal brain, and the lid with hole to perform surgery is closed. In figure 1, one can see the amniotic membrane unit unit as shown here. In figure 2, there is a cup which contains animal brain and the amniotic membrane unit. So brain with the amniotic membrane unit can be placed in the cup. And figure 3 and 4 is the finished model with trocar placed on both sides, and the monopolar cable is also entering inside the container. The indigenous inexpensive model can be made using orange, and dissection of the skin and the septas of the orange can be performed under endoscopic control. The ice cream stick can be used for simulation of the lamina. Low-cost exoscopic training using a notebook computer, a webcam, and a LED light source can be used. And you can also use USB camera as a neuroendoscope. The boroscope video also can be used for learning endoscopic surgery. So this is a USB camera which can be used as 0-degree, or it can be bent and used as 30-degree endoscope. And same way the boroscope video also can be used. These are inexpensive as compared to endoscope, light source, and cameras. The simple models can be made better. You can augment vessel. The pulsatile perfusion pump filled with artificial blood solution can be used for pulsatile blood flow system, and management of intraoperative vascular injury during endonasal endoscopic surgery can be learned. To control bleeding, one should place cotton first on the bleeding point under the endoscopic control. Cotton prevents lens swelling. Hold the cotton by the forceps and keep suction on the cotton for some time. Hold cotton by forceps, keep suction on the cotton for some time. Bring muscle and put it near the cotton. Keep both cotton and muscle near the bleeding area. Do not bring the muscle after removal of the cotton. By the time you remove cotton and bring it, the blood will stain your endoscope. So simultaneously remove the cotton, and side by side you put the muscle on the bleeding point. This is the simulation model for repair of the vascular injury. You can use plastic tube which can simulate vessel which can be torn, and then you can apply clip under the endoscopic control, or you can use some animal vessel and connect it with the tubings which has a colored fluid, and the control of bleeding can be performed using these simple models. The CSF augmentation for dura or intradural technique learning can also be performed. One can use perfusion in a fresh cadaver and do the spine surgery, or surgery for CSF leak for endoscopic endonasal surgery. The tumor simulation by gel can also be done. One can use detachable animal component which allows enhancement of the artificial model. One can use choroid plexus, ependymal vein, and the membrane of the floor of the third ventricle, which can be derived from the animal tissue and which can give rise to lifelike appearance. So to summarize, the various simple model for basic learning in endoscopy can be ice cream stick for simulation of the lamina, boiled egg for cellar floor drilling, precision training by working on predetermined line, Foley's bulb for dura. One can also use commercially available skull models for transcription humanoid exercises. Animal tissue can be used for dissection. One can use chicken wings. Rubber tube or the animal tissue can be used for vessel simulation. A bell paper filled with saline can be kept inside the skull model, and endoscopic training can be done. Animal tissue is placed inside the plastic box and various endoscopic procedure can be learned. Amniotic membrane and animal brain can be placed inside the soda cup. Peeling of the orange skin and the septa can be performed. Simla mirch or capsicum can be used for endoscopic training. The inexpensive computer, a webcam and LED light source, USB camera and boroscope, etc. can be used to simulate endoscope. 3D models are useful. Affordable models using 3D printers can accurately reconstruct patient-specific important surgical landmarks such as dura mater, venous sinuses, cavernous sinuses, internal carotid arteries, median and lateral opticocarotid recess, median canal, and cranial nerves. Exact model which are anatomically accurate and patient-specific using 3D printing can be used for training and surgical planning. Synthetic, thermoretractable, thermosensible rubber combined with the different polymers can be used reproducing surgical situations as if they were real and presenting great similarity with the human anatomy. Models for ETV, ventricular structures, craniosynostosis, sinus surgery, tumor that bleeds can be made. Fusion of 3D printing and spatial effect with the help of simulation engineer and a group of special effect expert can be made. As shown here, 3D printing models can be prepared. So which method of training is better? For basic training, with virtual reality simulators can be useful during the early part of your endoscopic learning. Cadaveric and animal model training still constitute an indispensable training tool. These have greater resemblance to the real operative conditions. Most educators believed laboratory training is an integral component of the training, and no respondent believed that simulation could in the present form provide greater educational benefit than the laboratory dissection. The participant in the two courses, UPMC and skull-based Congress participant, they favored live surgery, animal model and cadaver model as against the computer simulations. So the percentage of people favoring three type of model, that is live surgery, animal model and cadaveric models, were more favored compared to computer simulations. The other question is whether the skill from one model can be transferred to another model. It has been found that the skill can be transferred from simulation based learning or from a dry model, that is the synthetic model, whether it is simple model or 3D model, to the cadaveric model. And it is also seen that the cadaveric model training has shown to transfer to the patient. The other question is how to assess the competency when you use these models. There are methods. One can use total procedure time. The hand motion tracking derived parameter also can be used. The touching the surrounding structure can give rise to alarm, which can also be used as assessment tool. Electromagnetic tracking devices were used to analyze the surgeon's hand movement as they perform the procedure. The movement data, that is the time, distance, the number of movements and the speed of the movement, can be compared. The motion analysis provided useful data for the assessment of the laparoscopic endoscopic dexterity, and the porcine liver model was found to be valid simulations for real procedures. The next generation microneurosurgical skill lab or the endoscopic lab should have all the facilities. It should have 3D surgical microscope and 3D endoscope, surgical drills, operating table with Mayfield head holder, complete set of microsurgical tools, the imaging facilities, and additionally one can have neuronavigation, surgical robots, surgical planning systems, 3D visualization, virtual reality by computerized simulation for training of surgical procedures, and visuospatial skills, neurophysiological monitoring equipment in order to conduct research into human factors in surgery, and role of workload and fatigue on surgeons perform can be judged. What is the situation in India? The need versus reality as far as simulation training is concerned. This was analyzed by Dr. Rajneesh Arora, and this was found that only few centers in India have these facilities of simulation in the training institution. We are one of them, including AIMS, PGH, Chandigarh, KEM, and SMS Medical College. Summary of skill training methods. Various training models, including live human surgery, cadaver with or without augmented pulsatile vessel and CSF perfusion, tumor phantoms, live or dead animal models, synthetic models, which can be simple models or 3D printing models which are accurate for the patient specific. These can be augmented with animal cadaver tissue or can be augmented with pulsatile vessel, and CSF augmentation can be done. Skill lab training, virtual simulations, and hybrid simulators can be used. Simple, inexpensive artificial models can be made using boroscope, simple camera, and simple tissue. Stage learning should be preferred. One should first use simple models to learn basic endoscopic technique, and then use animal models, and then one can use augmented cadavers as preferred method of training. Model skill can be transferred from simulation models or virtual reality to the cadaver and then to the live surgery. Although most survey favored live surgery, animal models, and cadaver as the most preferred training model now, in future virtual reality may also become favored method. Neurosurgery skill lab with basic and advanced training should be there in all teaching hospitals. You can watch various endoscopic teaching videos on neurosurgical TV series by me and my own channel, and also Digi Neuro channel. I am thankful to my teachers. Thanks.